We now come to the final part of the symposium on odontogenic tumours, and we're going to look at a number of tumours which have both a neoplastic epithelial component and a mesenchyme component. That's what we term the mixed odontogenic tumours. And then those which solely comprise odontogenic mesenchyme. Then very briefly at the end, I'm going to mention malignant odontogenic tumours, which are extraordinarily rare. So first of all, we come to group 2, and these are lesions which comprise odontogenic epithelium and mesenchyme. When you have odontogenic epithelium and mesenchyme together, you then have the possibility of the formation of true dental hard tissues. Two main neoplasms are the ameloblastic fibroma and the Dontogenic ghost cell tumour. If you remember, we mentioned very briefly in the cyst lecture the calcifying odontogenic cyst, and this is the solid component of that, which is thought to be neoplastic. Adontomes, as far as the classification of these lesions goes, do fit into this category. We've covered them in an earlier lecture, and Dr. Elcock will also have covered them in dental malformations as well, and these are hamartomas. So what about ameloblastic fibroma? Well, this is again is another benign odontogenic tumour. It tends to occur in younger patients under the age of 20 and most often in the mandible. There is a little bit of controversy about these. Some people believe that, in fact, they're not true neoplasms, that they may well just be developing odontomes caught very early. But I think there are probably a spectrum of activity here, and some lesions which may well be just very early odontomes through to some which truly are neoplastic. Most often occurs in the mandible and has a well-defined radiolucency. Histology is quite classic, and I think the histology of this is one of the prettiest histology of a neoplasm in any human body site. I know you might think I'm just absolutely crazy for saying that. It does look a bit like 1970s wallpaper, right enough. And here you have both an epithelial component with these branching strands of odontogenic epithelium in this background of odontogenic mesenchyme. It's not fibrous like ameloblastoma. The background here looks like primitive pulp. And so when you have a look at it a bit higher power like this, again, you can see the things that we saw in ameloblastoma. There are the outlined of the nests by these columnar ameloblast-like cells, stellate reticulum area in the middle, and then this primitive pulp-looking odontogenic mesenchyme in the background. And there are some cases that you might find that because you have the odontogenic epithelium and the mesenchyme, that you will get little bits of dental hard tissue formation in these. And some of these are referred to by, the names just get longer and longer, ameloblastic fibroodontoma and so on. And again, there's a lot of discussion over once you do get true dental hard tissue formation in these lesions, what are they? Are they hamartomas or are they neoplasms? And we were planning at our international conference this year to have a debate on that, but that unfortunately due to COVID hasn't happened. The Dontogenic ghost cell tumour again is another benign tumour. It's pretty rare, we don't see very many of them. And they tend to occur in patients that are a bit older, 40 to 60, more males, and can occur in both the mandible or the maxilla. As far as the radiographic appearances are concerned, there's quite a lot of overlap between things like CEOT and Dontogenic ghost cell tumour because they tend to be relatively well outlined tumours. They can be quite large and expansile, but they will have calcification in them, and that's where the overlap with CEOT comes. As far as histology is concerned, the epithelial component resembles ameloblastoma. Because of the mesenchyme component, you get dentine formation. And there is an overlap, as I indicated earlier, with the calcifying odontogenic cyst, with really that being a benign odontogenic cyst, a developmental cyst, not a neoplasm, and this solid version, the Dontogenic ghost cell tumour, being neoplastic. So here's a radiograph I think you might have seen earlier. Is a large radiolucent lesion here, but it's definitely got calcification within it. It is displacing teeth. It is expanding the mandible. All these features that we know of a lesion which is somewhat aggressive. Histologically, They tend to have epithelium which looks like this. Not very much epithelium to see here, but lots of these cells. And these we term ghost cells because there's no nuclei in them. You can see the white spaces here, but all that's left is the kind of ghostly outline of the cell. And so that's why we call them ghost cell tumours. And they can become calcified, and that is what gives the calcification on the radiograph. But you're not going to see these very often. They're really quite rare. What about odontomes? Now, don't want to labour the point because you've already had this in other circumstances, but for completeness' sake, odontomes are hamartomas, that is, that they are developmental abnormalities, but they grow within the growth period of the patient, within the developing dentition. You can get them in the mandible or maxilla. And sometimes you get a variety of radiographic appearances all through from a really very poorly defined radiopaque mass, which has got no structure to it at all the way through to little collections of teeth. So there are two main types. There's a compounded odontome, which is more common. Tends to occur in the maxilla, particularly the anterior maxilla, and particularly at that within the premaxilla. Incisor canine regions, they are small, non-aggressive. They're not going to cause any problem. Of course, they may, because of their space occupying, result in displacement of teeth or impeding eruption of teeth. And when you have a look at them radiographically, they are like a collection of little teeth, or denticles, we refer to them. So here's a radiograph, and you can see the overlapping little bag of crowns on the radiograph. And when you look at the histology, these are like little individual teeth. The space here is where the enamel would be. There's a bit of pulp space in the middle. The relationship of the dental hard tissues is pretty much like you would expect to see it in teeth. Pretty well-formed lesions. Opposed to that are the complex odontome, which tend to occur much more in the mandible, particularly in the posterior area in younger patients. And in many cases, they are picked up because there is a tooth missing from the arch, and that tooth may actually be quite markedly displaced by the development of this lesion. And rather than being well formed into little teeth, it tends to be a fused mass of very haphazardly arranged tooth tissue. But you can recognize them as dentine and enamel and a bit of odontogenic epithelium, so you know that all the component parts are there. So here's the sort of thing that we see in a complex odontome. Here is there's a couple of displaced teeth, and there is a well-defined lesion here. It's got a nice radiolucent rim to it, but mostly the radiopaque because there's a lot of dental hard tissue formation associated with the crowns of these teeth. Obviously, impeded eruption displaced the teeth, and therein lies the problem with these, is that they will impede eruption of teeth, or alternatively at times, as may be the case here, they might actually breach the mucosa, almost try to erupt. And because they're so irregular, they then become colonized by bacteria and are then a focus for infection. When you have a look at the histology, you have to look a bit harder this time just to see exactly what the tissues are. And there's dentine here, there's a bit of odontogenic epithelium, this lighter staining material here is enamel matrix. So all the component parts of dental hard tissue formation are there. Sometimes they will be very oddly placed. Here's a little odontome present associated with an unerupted upper right 8. And that's the gross specimen. It almost looks as if it's stuck on the side. Quite well formed, actually. And at times with these ones, which look a little less haphazard, it can be difficult to put them definitively into the compound or complex category. It doesn't really matter very much. The last group of benign odontogenic tumours are those which comprise odontogenic mesenchymal alone. That's the group 3 lesions. In here we have the second most common true odontogenic neoplasm, which is the odontogenic myxoma or myxofibroma, and then a couple of others beyond that, which are less common. Again, the odontogenic myxoma tends to be a destructive lesion. It's benign, but it can be locally destructive, like ameloblastoma and CEOT. It tends to be younger patients, most in the mandible. We do, though, get some in the maxilla, and they can be particularly troublesome for treatment and getting complete excision. They tend to be slow-growing, painless swellings, very often found incidentally, and because they are mesenchymal alone, they don't have any dental hard tissue component to them, so they tend to be radiolucent. The classic description of odontogenic tumours being radiolucent with a soapy bubble appearance has actually come from odontogenic myxoma because the locules tend to be that little bit smaller. And again, as for ameloblastoma, you can get root displacement and resorption and so on. Histologically, which I'll show you, it's a very loose connective tissue, really very little to see histologically. And the treatment, because they are destructive and they do have a tendency to recur, tends to be very similar to that of ameloblastoma. So here we have a lesion which turned out to be an odontogenic myxoma in the anterior part of the mandible. It is a relatively well-defined and partly corticated radiolucency. It doesn't really look particularly multilocular, it looks fairly unilocular in this case. It's involving the apices of these teeth, but it's very difficult on an OPT to see whether in fact there is any root resorption here. It's very difficult to ascertain that. But here's a more spectacular example, which is much more along the lines of the ameloblastomas that we saw earlier. This is very definitely a multilocular lesion, which is extending probably from about the parasymphysis all the way up to the high part of the ramus of the mandible with this displaced lower third molar. It's relatively well defined, but in this case, not really corticated. And you can see the little compartments that this tumour is separated into. Even more obvious when you have a look at it in an excision specimen, as in this case, you maybe get an idea of why the soapy bubble appearance has been called, but very definite multilocular radiolucency of the mandible and the expansion that goes with that, which you can also see in the clinic, the photograph, the gross photograph of a different excision. Histologically, there isn't really an awful lot to see, and this picture here, which has become a little bit shrunk for some reason, does show you the very loose connective tissue in the center, and then these struts of bone which are separating the tumor into all these different compartments. When you have a look at it at higher power, spindly fibroblasts, and really not an awful lot else to see. And it's very easily separated from the surrounding tissue, as you can see here. Here's the bone around the outside, and this loose, reasonably cellular connective tissue with not very much collagen in the background of it. It's not particularly pink. Lesions which are very fibrous tend to be called odontogenic fibromas, and they're different from odontogenic myxomas because they do not seem to be as aggressive. They occur over a wide range, both males and females, both in the mandible and the maxilla. And you can get central types, that's those which arise within the bone of the jaws, and others which arise in the gingiva, so which are called peripheral lesions. If it arises as a central lesion, it's most often a unilocular radiolucency, and histologically they tend to have mature fibrous tissue, and you can have occasional odontogenic epithelial rests scattered throughout it, but they're not a neoplastic part of the tumour. It's a fibrous neoplasm in this case. The last lesion is one which I raised all the way back in the earlier part of the course when we were looking at periapical pathology, and that's a cementoblastoma. And this is a benign neoplasm of cementoblasts, as the name would imply. It tends to occur in younger patients and affects teeth in the mandible, usually the lower first molar. That's by far the most common tooth. And what you get as a cementoblastoma is a radiopaque lesion, which is attached to the root of the tooth and then has a radiolucent rim to it. So it is very clearly separated from the surrounding bone of the jaws. Histologically, sheets of cementum and cementum-like material with very active, plump-looking cementoblasts. And it actually is very similar in many ways to osteoblastoma, which is the analogous lesion of bone. But the difference here for cementoblastoma is that it is attached to the root of the teeth. And that is really what's very important, allowing you to make the definitive diagnosis. So here we have the radiology, radiopaque lesion, a attached to the roots of the 6, got a radiolucent rim to it. Take it out, as you can imagine, that would be a rather difficult extraction. You can see it's definitely attached, and there's this massive cementum, which is very poorly formed, attached to the root. And here we have dentine of the root, and then this very poorly formed sheets of cementum, lots of very active looking cementoblasts in there forming new cementum. And it's a lesion which is benign. Once you excise it, it's not going to recur. So that's all the benign odontogenic tumours. We split them, I guess, to some extent for convenience into those epithelium only, epithelium and mesenchyme only. Lastly, and just in the last slide or two, is just to introduce the whole idea that, in fact, there are malignant variants of these tumours, and these are extremely rare. We're talking about only seeing a handful of these cases in any centre over decades. And there are a number of these, largely in relation to the epithelial component. There are odontogenic carcinomas like ameloblastic carcinoma, primary intraosseous squamous carcinoma, and others. And there are also, and even rarer than this, there are odontogenic sarcomas as well. Now, as you can imagine, the benign odontogenic tumours are destructive enough. The malignant tumours tend to be even more so. And here's an example of an ameloblastic carcinoma in a patient, and it looks as if that whole right side of the mandible has just been blown apart. There's essentially a pathological fracture. It's a large, expansile, sort of radiolucent lesion, but it's actually very difficult to define the parameters of this lesion at all. And this was an ameloblastic carcinoma. It needs to be treated very much in the same way as you do any other malignancy in the maxillofacial region. So what about further reading? Well, Soames and Southam's Oral Pathology, Chapter 6, covers all these lesions and some more. And a more digestible, shorter form, perhaps, maybe Dr. Briley and my paper that you can pick up from Diagnostic Histopathology if that's something that interests you. And that's the end of the symposium. Thank you for your attention.